Should we, what should we use for weight? And by and large, unless someone is really varies more than 30% in either direction, we're going to just use their actual body weight. And then for nadir, which means kind of it's the lowest point, right? So it's the valley. When you start off having chemo, you're at your peak, and then in this case with carboplatin, it starts killing off your white blood cells. You reach kind of that lowest point at 21 days, and then you start to recover, so that hopefully by the time you get ready for your next dose, your white counts, your red counts are up high enough to continue. That's not necessarily easy for patients to have that happen, because if the nadir is about 21 days, and most of the time the cycles are every 21 days, it's fairly common for me to have to delay patients or dose reduce them, because they're just not able to maintain white blood cell counts and red blood cell counts. So usually what that means is an ANC, or an absolute neutrophil count above 1,000, or a platelet count above 100,000. And there are some exceptions, and different institutions have different guidelines. So for example, at my practice site at CCI in Clovis, they usually have the cap at 1,500, an ANC of 1,500, which is pretty high. Most places have it at about 1,000, because otherwise you're constantly calling the physician or the nurse practitioner or the pharmacist, hey, can we treat today? Is it okay? Because they're, they're like 1,450 or whatever the ANC. So in terms of ADRs, biggest thing is bone marrow suppression, nausea and vomiting, delayed nausea and vomiting. Sometimes people can get pain, like joint pain and kind of discomfort. Renal toxicity we definitely see, and we don't dose reduce specifically for renal toxicity because you're having to dose based on their renal function. Does that make sense? Okay, so a lot of times nurses will come to me and they'll say, oh, we need to dose reduce, the patient's serum creatinine is rising. Well, yes, they're going to get a lower dose because it's dose based on creatinine clearance. All right. Let me see here.
Dr. Leda, I have a question. When you said that, if their blood count is too low, you don't give them this medication. Do you give them something else, supplement while you're waiting for it to increase, or do you just wait altogether?
We usually wait altogether. And when we get to the neutropenia section, I'll talk a little bit about when we intervene. But ordinarily what will happen is, unless someone is really at a high risk for developing an infection, we'll just dose delay them. So if they're supposed to get it every 21 days, and let's say you're at 22 days, and they're supposed to get their next dose of chemo, but their counts are too low, but they're not sick, their counts are just not low enough to be safe, usually we say to patients, you know what, let's recheck in a week, let's see how you're doing. And if you're okay, we'll go ahead and try again. Sometimes what we will do is, if I know that after 2 doses, the patient consistently keeps having these low, blood counts and it's delaying them, I'll probably dose reduce. So if I'm giving an AUC of 5, I might do 4 instead, so that the area under the curve of their exposure is a little bit lower if I know that their bone marrow can't support it. Does that make sense?
Yeah, thank you.
Cool.
Dr. Leda, I have a question as well. For carboplatin, is there any pre-treatment or pre-medication that we need to give before we give the dose?
Yes. So all the pre-medications around carboplatin are entirely based on the immunogenicity. So the likelihood that it's going to cause nausea and vomiting. When it comes to pre-medicating for allergic reactions, if I know that I have to have a patient continue past the 6th dose, I might consider adding an H1 and an H2 blocker, or potentially in addition to the steroid. The nice thing about the immunogenicity profile of this is that we're typically going to give somebody dexamethasone anyway to help prevent the nausea and vomiting, and that is really good at helping to also prevent an allergic reaction. So sometimes it has kind of a nice crossover.
Thank you.
Good question. All right, so cisplatin is kind of carboplatin's nastier, bigger sister. Definitely patients deal with a lot of nausea and vomiting. You know, bone marrow suppression isn't quite as bad, but there's some other toxicities that can be really serious. So a couple things for patients, and, you know, I'm not going to necessarily make you memorize, like, you know, you can't exceed 1 milligram per minute of administration or anything like that. But what we do to help prevent some of the renal toxicity that we know happens with cisplatin, because cisplatin is not dosed using the Calvert formula. We dose it based on milligrams per meter squared. So we want to hydrate patients, and the dose of the cisplatin then dictates how much pre and post hydration we give. So if I give big doses of cisplatin, I give, you know, at least a liter pre and a liter post. If I'm giving much smaller doses, then I usually will give, like, you know, 500 mLs before and 500 mLs after. It really just depends. But what's important to know is whenever you see cisplatin, you know you have to give pre-hydration and post-hydration. And one of the things we do with the pre and post-hydration is we usually add electrolytes to it. Because one of the things we know about cisplatin, its nephrotoxicity results in electrolyte wasting. And so people will have very low levels of K. They'll also have very low levels of magnesium. And so one of the things that we do is we usually give like a gram or 2 of mag pre and 20 of K pre, and then repeat that post within the hydration. The other thing is, it actually, depending on the concentration, can be at higher concentrations can be a vesicant. So that means if it extravasates, if it leaks out of a vein, it can cause necrosis and damage. And that can be very serious. And then at lower concentrations, it's an irritant. So we try in general, the problem with cisplatin is that its concentration is 1 milligram per ml. So if you're giving somebody like 200 milligrams, you're putting 200 mLs into a bag. So usually you'll see, like, you know, the bag will be really full, and depending on the concentration, you might have issues where it might be a vesicant. Dose modifications, you know, basically, if you've got a creatinine clearance that's 30 or equal to that, we don't recommend it. There's not like a firm cutoff, like you shall not give it. But in general, I'll see if I can switch it out for carboplatin, unless I know that there's no activity that carboplatin has for a particular cancer. But I would say that cisplatin and carboplatin are fairly interchangeable for a lot of different kinds of cancers, especially head and neck cancer. Incidentally, so I mentioned that carboplatin is a radiosensitizer. Do you think cisplatin is also a radiosensitizer? Yes, it is. We combine it with radiation all the time because it has a really good synergistic effect. So for monitoring, kind of same stuff as for carboplatin. The slight difference that we add is it can cause quite a bit of neurotoxicity, so like numbness and tingling in fingers and toes, ototoxicity as well, so people will hear ringing in their ears. I've had to stop a number of patients on cisplatin and switch them to something else because they started having like tinnitus or losing the ability to hear certain pitches. So we want to, in addition to watching out for, you know, nausea and vomiting and bone marrow suppression, things like that, we also want to pay close attention to the neurotoxicity and ototoxicity. All right, so really fast, somehow these got messed up here. Carboplatin should have been after the carboplatin. But for Mike D, so what would his dose be? See if I can. So he's 6'1", and, or sorry, he's 61 and he's 6'1", and he weighs 172 pounds. And we figured out his creatinine clearance based on the serum creatinine labs I gave you. And we're using an AUC of 5 for the carboplatin. which is a typical dose for head and neck when we're not combining it with chemo. So we're going to use the Calvert formula, which is the creatinine clearance plus 25, which is just a fixed factor that you always add, times 5. And for this patient, we'll give him 740 milligrams of carboplatin. And just so you know that when patients, in most institutions, if a patient has a change in body weight or creatinine clearance that's equal to or more than 10%, that usually means we have to recalculate their dose. Because we want to make sure that we're not giving somebody too much or we're not giving them too little of a dose as well. Believe it or not, a lot of patients gain weight when they're on chemotherapy. So either because they start feeling better or it's because we're giving them a bunch of dexamethasone. But it's not uncommon for me to have to increase the doses of chemo because patients gain weight. Any questions? All right.
Yeah, I have a question.
Yeah, what's up?
Yeah, so look at the surface area. The age, you have 6, 5, and 4. So what prompted you to choose 5 instead of 6 or 4?
Yeah, so it really just depends on the type of cancer they have and also the protocol. So generally speaking, we use an AUC of 6 for like ovarian cancer. We tend to use 4 or 5 more for most other kinds of cancer, including breast cancer, head and neck. So it really just depends on what you're treating and what regimen or protocol you're using. So it'll change based on, again, what the data shows is most effective, if that makes sense. So what I did was I just put this here because it's an easy reference so that I know, if, let's say, for example, I've got a patient and I'm just really quickly checking chemotherapy, and I don't necessarily want to go through, multiple rounds of all the different math, I can at least do a gut check of, okay, is this AUC reasonable because these are the max carbo doses for each of those AUCs. Does that make sense?
Okay, yeah.
Cool. All right. So taxanes. So paclitaxel, kind of switching gears. This is also radiosensitizer, and it's an irritant, so it can, cause irritation when it's being given peripherally. Now, for this guy, we must pre-medicate because it's formulated with Cream-4 EL, which is castor oil. And interestingly enough, the issues that patients deal with, like from a reaction perspective, when they get taxanes, is actually because of the vehicle. They're reacting to what it's dissolved in. They're not necessarily reacting to the taxane. So we always give a first-generation antihistamine. Sometimes we'll do second-generation, but Benadryl really works better. We give them dexamethasone, and we always give one of my favorite drugs in the entire world. I give it for everything, Pepsid. I love Pepsid. Pepsid is a badass drug, man. It blocks histamine. It helps deal with stomach upset, and it's just fabulous. And it works for allergies too, by the way, especially in combination with different non-sedating antihistamines. Also, the other thing is that we always use a special tubing and inline filter. These are things that you might get asked possibly on the NAPLEX. They used to ask these kinds of questions a lot more. We're seeing a bit of a change in the kinds of questions they're asking for oncology, but anything that's really like kind of out of the ordinary that you need to know, especially when you go on rotation or you do a hospital rotation, just know that we don't put them in the regular bags. It can't be in a PVC bag. It has to be in one of those Braun XL bags, or the ones that they always show on Grey's Anatomy that irritates me because I'm like, they're very expensive and we don't put all drugs in the shiny ones. And then for doses, if we do less than or equal to 100 milligrams per meter squared, we can run it over 1 hour. For any doses above that, we have to run it over 3 hours because patients will have a reaction if you run it too fast. And then we'll do some dose modifications based on hepatic toxicity. It happens sometimes. I don't tend to see like full on, fulminant like hepatitis, but I will see a rise in ALT, AST, sometimes alk phos as well. It's got a low emetogenic risk, so between 10 to 30% of patients might have some usually delayed nausea, but that's not a common complaint. So when I think about Taxol, I think allergic reaction, possible, right? I think low emetogenic risk, and I think of neuropathies. So those are really the things that I think of when I think of Taxol. In terms of monitoring, we're always going to check CBCs with DIF. So the good news is in oncology, there are a lot, well, the bad news is there are a lot of drugs. The good news is we pretty much always check for CBC and a CMP. So if you choose that, you're pretty much not going to be wrong. So there are some other things that you will need to know too, but generally speaking, you can't go wrong with that. The nadir tends to happen in about 10 to 12 days, and it takes patients about 15 to 21 days from the time they got their dose to fully recover from the lowest point. So some of the major reactions are anaphylaxis, like I mentioned, bone marrow suppression. We do see a lot of neutropenia, especially for the bigger doses. Alopecia, people always lose their hair. So for carboplatin, cisplatin, patients lose their hair, but with taxanes, they really, it's typical for patients to be totally bald. Taxanes are also notorious for radiation recall. So a patient can have had radiation a while ago, receive a taxane, and then the field gets irritated. And peripheral neuropathy is extremely common. So my patients describe it as like bubbles under their fingers and toes. And I would say that of all the rate-limiting toxicities, neuropathy and Taxol are probably the biggest reason why we either discontinue the drug or we decrease the dose. And then also I'll have patients complain of myalgias and arthralgias. So their muscles and joints will hurt usually for about 24 to 48 hours after they have their dose. Okay, so contrasted with docetaxel, so what I'm trying to do is I'm trying to create different profiles in your brains of like how not to mix up these drugs, okay? So unlike Taxol, which has the high risk of neuropathy, but kind of lower risk of severe neutropenia. Taxotere, docetaxel, tends to have a much higher risk of bone marrow suppression, really severe neutropenia. But the neurotoxicity is not quite as severe. So I would say that very rarely do I have to take somebody off docetaxel because of the severe neuropathy. I'm more likely to have to decrease their dose or stop them completely because of bone marrow toxicity. We also do pre-meds. Now, I have this here, pre-med dex 8 milligrams, starting, 12 hours before chemo and 3 days starting, or continuous after. A lot of places are doing away with this. CCI included, and we're just giving a single dose of dexamethasone, 20 milligrams, like the day that they have chemo. And the reason for that is we were seeing that patients obviously can have a risk of reaction because it's not made with Crema-4EL, but it's made with a similar polysorbate 80, which tends to cause reactions very similarly to Taxol. But the issue is that patients also sometimes will get fluid retention, and so we found that if we gave them this pre-medication of dexamethasone, it really helps decrease the amount of fluid retention that they were having. And then some formulations are made with alcohol, and so patients would tell me, and before we really knew this, patients would sit in the chair, and some of them would actually basically act drunk. It was very bizarre. And we forwarded some concerns to MedWatch and to the FDA, and they did a bit of an investigation, and then they released this big statement saying, make sure you tell your patients not to drive after they get docetaxel, because some of the formulations basically have like pure ethanol in them. So they have separate formulations now that don't have alcohol. And then we, of course, want to monitor same things as we do for Taxol. And I have this here, take your dexamethasone as directed, because I think for board exam purposes, they're still, saying this because it's in the package insert, but none of us do this anymore. So much fun. Things change every day. All right, really quickly, antimetabolites. So moving on to 5-FU. Normally with 5-FU, we divide the dose and we run it kind of continuously for therapy. So we'll give like a continuous infusion. And for like colorectal cancer, we'll give it over a couple of days. When we combine it with radiation, we usually give it over 5 continuous days. And we send patients home with a pump. And you can actually see this pump here. It's a CAD pump. How many of you work in the hospital right now as interns? Not many, right? Okay. Have you seen one of these CAD pumps?
No, I'm not sure because they do the infusion room. The nurses always come pick up the meds. We never go up there.
Ah, okay. So we use a variety of different pumps that we send patients home with, and when you send patients home with a pump, you have to make sure they have a home to go to. So one of the things that we don't want to do is when patients are homeless, we don't want to send them out into wherever they're living with a pump. So sometimes we'll actually have to switch therapy to something else, or we'll give them the oral prodrug instead, because it's not safe for them to take them under underpass or wherever it is that they're living. Sometimes we'll give a bolus dose in addition to the continuous infusion, and that's given over about 10 minutes. We just put it in a syringe and push it. The problem is that we found that it causes a lot more than mucositis, which is the kind of the breakdown of the oral mucosa. It doesn't interfere with, so allopurinol interferes with the activation of 5-FU, so we try not to combine those two because it can decrease efficacy. CBC, obviously we do that. Sometimes there's some neurotoxicity that can happen, so we kind of check in with patients about that. Some of the things that we worry about for severe ADRs, stomatitis, right, so that mucositis. Hand and foot syndrome is a big one, so I'm going to show a picture in a minute. Diarrhea, photosensitivity, so I always tell patients wear sunscreen when you go outside because 5-FU can actually enhance the effects of sun. It very rarely can cause an acute cerebellar syndrome as well, which patients will have ataxia, visual disturbances, confusion. That's fairly unusual, but it can happen if patients overdose. So one of the reasons I bring this up about it being put in a pump over, 2 or 5 days is that there have been several instances where nurses or pharmacists have not put in the correct time in the pump. They haven't programmed it properly. And so patients, instead of receiving a dose over, 96 hours or 48 hours, have received it over like 2 or 4 hours. And that's actually resulted in a fair number of deaths, which is why they finally developed an antidote to 5-FU, which is Vistagard. And if we suspect that someone's been poisoned by 5-FU, we go ahead and give them 10 grams orally every 6 hours for 20 doses. So this happened commonly enough that unfortunately we needed to develop an antidote. But this is a drug that you'll see fairly often for a number of different kinds of cancers. This is the hand-foot syndrome I was talking about. It's very painful, and patients can have kind of desquamination, so the soles of their feet and hands will kind of slough off. This is a pretty severe example. There's a couple of other drugs that can cause a similar type of hand-foot syndrome, but this is a major dose-limiting toxicity when this happens.
Dr. Leyva?
Yeah. Mm-hmm.
Is that hand and foot syndrome the same thing that is prominent in daycares?
No, that's interesting. So hand and mouth syndrome is actually caused by a virus. So for little kids and stuff who pick it up at daycare, that's actually caused by a viral infection. But that's a good question. Yeah, you're right, because they do sound very similar. This is caused exclusively from the exposure to chemotherapy. So just really quickly, capecitabine or Xylota, it's a prodrug of 5-FU. Same thing, nothing exciting here. We just tend to give it days 1 through 14, of a 21-day cycle. We always want to take it with food. So that is an important thing to remember. When you counsel patients, take with food. Another thing that's really important is, for those of you who maybe work in specialty pharmacies or handle some oral chemotherapies, always use gloves. These drugs are toxic to cancer patients, and they're toxic to you when you handle them, okay? So make sure that you don't just, use your fingers to count all the pills and then grab a bag of M&Ms and start, eating whatever. No, that's bad. You want to make sure that you use ASTM chemotherapy-approved gloves. And then one thing that's really important is we want to avoid warfarin, because this is a strong CYP2C9 inhibitor. And if your creatinine clearance is less than 30, it's contraindicated. So we don't give it because we know that it's not going to metabolize appropriately, and patients are much greater risk for hand-foot syndrome. And, again, it can cause the same kind of toxicities as 5-FU, so there's nothing really new here. The one difference I will say is that it does tend to cause a lot more diarrhea, and diarrhea tends to be the reason why we will dose reduce patients. All right, methotrexate, we're going to get to this drug later, but I just want to kind of remind you of it because you've already had methotrexate. We give it in a variety of different routes. When we use it for things like ectopic pregnancy or rheumatoid arthritis, psoriasis, we use much lower doses. When we use it for cancer purposes, we give much higher doses. The difference is if we give it intrathecally. Now, some of you may have seen this like on hospital or IPI rotations. Can you think of why we only use preservative-free versions for intrathecal administration? First of all, do you guys know what intrathecal means? Oh, you're muted, Ryan. I saw you talking.
Well, it was more just, spinal column.
That's right. Yep, it's within the spinal cord space. So we only want to use preservative-free versions because any of the bacteriostatic or preservatives that are used for like a regular IM or IV injection or sub-Q, for example, can cause major toxicity, neurotoxicity to the body, and that can actually kill people. So when you look and you check a bottle, if you're preparing an intrathecal preparation of any medication, you want to make sure that it's preservative-free, always. And then we use high doses often require an antagonist called leucovorin so that we don't have patients die of toxicity, and we will we'll measure their peaks and troughs, kind of similar to how we do vancomycin. But we'll talk more about that when we talk about leukemias. Just as a reminder, we want to check pulmonary function, LFTs, renal function, CBC, stuff like that, because it can cause quite a bit of general toxicity for patients. All right, and just quickly about Erbitux. I mentioned it's an anti-EGFR. This guy we got to pre-medicate because you see the X there, that's chimeric, right? So whenever we see chimeric, that often means that you have a much higher risk of reaction. Really interesting thing about this guy. So first of all, we do a loading dose, okay? So the first dose is higher, and if it's concurrent with radiation, we have to give the loading dose 7 days prior to radiation therapy to give the body a chance to really have that synergistic effect. And we notice that patients have a lot of magnesium wasting, potassium wasting, things like that, so we want to monitor for that while they're on therapy. One of the things that's really interesting, though, is when this drug first came out, I was giving a lot of it for patients who had colorectal cancer. I wasn't having any problems other than the acneiform rash, which is very common, and I'll show that in the next slide. I went to a conference, and a couple of my colleagues were saying, we've started using Erbitux, and we're seeing severe reactions. Like, had friends who had patients have fatal reactions to Erbitux while sitting in the chair. And this was all concentrated in the Southeast. And we thought, well, this is really weird. I'm in Northern California, you're in the Southeast, what's different? Well, what we discovered finally was that the severe allergic reactions that were happening in the southeast and now because of climate change in the northeast too had to do with a bite from a Lone Star tick. And so there was a cross reactivity with some of the antibodies, and the patients who had been bitten by this particular tick were having these severe and sometimes fatal reactions to Erbitux. So it actually prompted a big discussion, and I think in some cases they do testing, or they don't use it at all. They use a different drug called panitumumab instead. So kind of interesting, right? Climate and ecology have merged here. So this is what the acneiform rash looks like. It's awful. It's really hard for patients because it's visible. And I have older patients who are like, I haven't had acne since I was 15, and now they're covered in it. And it can get weeping and oozy. So one of the things we do is we want patients to use moisturizers, alcohol-free cleansers, and then often we'll either start them off with doxycycline or minocycline to help prevent the rash from happening, or if it gets bad enough that patients are uncomfortable, we'll go ahead and give them doxycycline or minocycline for the entirety of their treatment. They could be on Erbitux for a very long time. So they'll continuously get these antibiotics for a long time as well. All right, so nivolumab, we're going to talk more about these when we talk about the immune-related adverse events. But just kind of quickly, we've got flat dosing now available for most of the anti-PD-1 drugs like Keytruda and Opdivo. And we don't ever dose reduce, we just hold for toxicities, unlike other chemotherapies. Some of the things we see are like hypothyroidism, hepatitis, basically any itis that you can think of is very common with the anti-PD-1 drugs because they're checkpoint inhibitors. They're activating your immune system. And then with pembrolizumab or Keytruda, kind of same deal. Flat dose, same toxicities, and we don't hold the dose. We just, or we don't reduce the dose. We just hold. Okay, so I know that was a crash course in a lot of drugs, but I did that to kind of prepare you as much as I can for the drugs that you're going to be seeing very frequently when we kind of move on to some of the different cancers. So before I kind of break you out into your groups, do you guys have any questions? No? All right, cool. Let me just get out of this slide.